I welcome you all to this month's powwow, November's powwow, and 13th powwow. And really grateful to Dr. LG, Dr. JB for joining us for this meeting. The aim of powwows is to connect with the alumni, Shankanetralaya alumni, from different specialities. So, very happy that this time we are taking it to the level of super speciality. So, thanks to Dr. Suganeswari, we will have interesting cases from ocular oncology. And I think we have a lineup of good cases by our fellows from the VR department and very, very learned panelists. So with that, over to you, Dr. GSI, to take the program forward.
Thank you, ma'am, for initiating the concept of having the grand rounds, online grand rounds. That is what this particular meeting is all about. And it is, as we usually say, this is like coffee with all of us. That is how it is, like evening coffee, where we are going to have a highly informal discussion so that all our basic doubts and some kind of good clarification we can get, and the people who are going to be the audiences who are going to be watching all these things, we hope that they will carry some good useful information from this particular meeting. That is what we are kind of addressing. And we have our esteemed panel, Dr. Lingam Gopal sir, who needs no introduction because sir has been the teacher for all of us, and we all know how knowledgeable sir is, and to get into the nitty-gritties, to have him on the panel is a blessing today. And Dr. Jyotirmay Biswas sir, who is the king of the uveitic disorders. So to have Dr. Jyotirmay Biswas sir with us, and we are going to be expecting them to actually guide us how to take through these patients. And so I thank Dr. JB sir for being here with us. And we have our pathologist, Dr. Krishna Kumar sir, whom I always say he's got an eagle's eye for anything to give the minute details. So here we are having some cases which are there, 3 case presentation. So which for us, the cases are going to be presented by Dr. Sai Divya. Is a vitreoretinal fellow currently in the VR department, and Dr. Sakshi Ramani, who will be presenting the cases. And then in between the cases, we can anytime stop. That is not a problem because this is going to be highly informal, and we can have a discussion at the end of every single case. And then we will see how so far we have reached with these patients and how we would like to proceed with that. So with that few words, I will invite our Dr. Sai Divya and Dr. Sakshi Ramani, who will be taking us through with the patients. So over to you, Dr. Sai Divya and Dr. Sakshi Ramani.
Very good evening to everyone. We'll be starting today's session. I'd like to thank GSI ma'am to give me this chance. The topic for today's powwow is pigmented puzzles in the choroid. We'll be dealing with 3 pigmented lesions in the choroid and see how each case, although with a similar presentation, has a very different diagnosis and how do we go about it. Starting with the first case, it's a 64-year-old male who presented with sudden loss of vision in the right eye since 19 days associated with pain. He gives us history of smoking for the last 10 years. He is actually a medico who has been worked up elsewhere. A complete panel, inflammatory and oncology panel was done, and we'll be enlisting only the positive findings. The UHG abdomen was a normal study, but he was PAS positive. On presentation, he had a visual acuity of 1/60 in the right eye compared to a 6/6 in the left eye, and his anterior segment was normal with IOP of 12 millimeters of mercury and a reduced color vision of 3/17. The left eye was normal with a normal color vision. On examination, his fundus picture looked like this. He had a diffuse lesion of from 12 to 2 o'clock in the suprarenasal quadrant, a irregular, diffusely pigmented with a variable pigmented lesion with an uneven surface. The blue autofluorescence showed hypoautofluorescent spots with a leopard spot-like picture. On infrared autofluorescence, this was the image. Again, the margins of the lesion can be seen, a very diffuse pigmented lesion with some hyper and hypoautofluorescent spots. On ultrasound B scan, there was a retinochoroidal elevation with homogeneous reflectivity in the suprarenasal quadrant. So again, this was a diffuse, uniformly reflecting uneven surface and had a normal subtenon space. The maximum height of the lesion was 4.63 millimeters, and there was an exudative retinal detachment associated with the lesion. We did FFA and ICGA to look for the lesions. So in the early scans, the FFA did not pick up anything, whereas the ICGA showed diffuse hypocynescence. Progressively, the FFA was again was showing very few hypoautofluorescent lesion. The ICJ with the same picture of the margins of the lesion delineated. The late phase of the FFA showed delayed staining, which was more peripherally situated. The central zone was more or less clear, and a similar parallel ICJ picture. So on his blood investigations, his quantiferon TB gold was positive, and he was already on anti-tubercular drugs. He did his PET-CT with fusion MRI, which showed a chorioretinal thickening and collection in the right eyeball with no significant FDG uptake. The lesion was measuring 1.6 into 0.6 centimeters. There was some FDG uptake noted in the pleural base consolidative patch in the left lower lobe of the left lung and some subpleural emphysematous changes. And there was also FDG uptake at the intestinal and hilar lymph nodes. So summarizing this case, this was a 64-year-old male with first episode of such a lesion. He had positive smoking and tuberculosis history, and the FFA was showing pinpoint fluorescence. What literature says is that we'll be taking choroidal melanoma as the basis of our diagnosis, but choroidal melanoma usually presents in a higher age group. This was literature says that 30 to 50 years, and recurrences are common, and there was a systemic disease association which was infectious, and FFA was showing leakage. So we came up with the diagnosis of an inflammatory pathology in this case.
So now I would like to request, yes, I think Dr. LG sir has raised his hand. Yes,
I just would like to ask you, were there cells in the vitreous cavity or no?
No, sir. Actually, there was no cells. The anterior chamber was also clear. Vitreous was also not having any cells, sir.
Was any OCT done to see for cells in the vitreous cavity anterior to the lesion?
Yes, sir. He had his OCT also done, and he himself was a medico, and he comes from a family of doctors. So basically, what was done was his entire workup was completely done for tuberculosis and for sarcoidosis also, and complete inflammatory panel was done. And because his age group was in the age of 60, so we had ordered for a PET-CT with an MRI. Of course, he did not have, he did have a history of COVID that was there. So he was having COVID, that was the only thing. And what we came across during the investigation was the quantiferon TB gold was positive in him. So what we actually decided was to start, he was referred to the pulmonologist because he was having all these lung lesions. And of course, the radiologist who interpreted the PET-CT also gave us a diagnosis as most likely because of the FDG uptake, it could be an inflammatory pathology. So he was started on ATT with, of course, the steroids as well. And he was also out of curiosity, what he also did was his treatment was initiated in the month of August. And then now he has undergone his repeat PET-CT himself. So in the repeat PET-CT, he is having improvement in the lesions, what that was, and his vision improved from 1/60 to 6/18 at the current situation. So my question to the panelist is, sir, if you encounter the patients like this, what would be your line of management? Because what we thought was, if we are not seeing any response at the end of 3 months, then in that case, we would decide to do a biopsy. If the patient is, because we have extensively investigated him and we did not get any positive thing apart from what the lung lesions are showing, and the pulmonologist did not want to go in for a biopsy from their side also.
Now, if I can put it across in the correct perspective.
Yes, sir.
The presence of a systemic focus of previous tuberculosis is fine, but that doesn't tell us necessarily that what is happening in the eye is related to that. So if we ignore to start with from the eye point of view, if we go start ahead, how are we concluding it as inflammatory pathology? Is it because of a systemic evidence, or is it because in the eye we find any inflammatory evidence of inflammatory lesion, like such a large lesion which is almost about 16 millimeters long?
Yes, sir.
And not very shallow either. I'm surprised that if that is tuberculous granuloma, that there are absolutely zero cells in front of it and media is crystal clear. Absolutely. Yes, I have seen tuberculous abscesses which are with a clear vitreous cavity, but that is in patients who are immunocompromised, where they don't react to the inflammation. But if it's an immunocompetent person, I would expect some cells in the vitreous cavity. That's why I said OCT, because OCT would show cells which may not be clinically appreciated in the posterior vitreous, although anterior vitreous spillover may not be still taking place. Second, such a large lesion, if it's a TB abscess or TB choroiditis, I would expect some amount of subtenon space widening in that area.
Very true.
Two reasons why inflammatory pathology, strictly from the ocular assessment point of view. I'm not talking about the evidence from the systemic point of view. There can always be coexistent tuberculosis in the lung. That doesn't mean what is in the eye is always due to that. Yes, it is important, we should keep it in mind, but strictly from the eye point of view, I would probably put inflammation not as a top priority, but a non-inflammatory thing, even a malignancy, as still a top priority. So biopsy still cannot be ruled out if there is no response to the ATT and systemic steroids. So, and the improvement is not assessed based upon PET scan, but an ultrasound evidence of reduction in the size of the lesion. So I would say the patient should be called back, because secondary RD can subside maybe because of steroids, etc. So that may cause improvement in vision. But if the lesion itself is the same or slightly increased in spite of ATT and steroids, I would say that's a red flag, really, that we are not dealing with inflammation. Thank you.
Absolutely true, sir. The plan was also the same. He is coming in the November month. So at that time, he's also being followed by another VR surgeon. So that is what is happening. So we have actually called him. The patient is coming this November. At that time, we are going to repeat the ultrasound here. And then if this is not suggestive of any change, that is no interval change, if it is being noted down, then in that case, the plan was to go ahead and do a biopsy. That was the plan as of now, sir. Because actually, if we see his FFA also, that is also not very, very characteristic of any inflammatory pathology. And more so going by, this tuberculosis is something which is detected only after we started evaluating. So he's not a positive history of tuberculosis was not there. This quantiferon and all the CT thing and all was done after the eye presentation was noted. So your point is well taken, sir. So we are calling the patient. Anyway, the patient is coming in November for us. So the plan was to see for the interval change and then decide further. Yes, sir. JB, sir.
See that I echo Dr. LG's concern and comments. Simply having the quantiferon TB gold test doesn't indicate that this is a tubercular etiology or tubercular association. The lesions does not look like, it should be the tubercular choroid. It should be start with a small lesion and it will go on increasing, and it will have some kind of an inflammatory reaction to start with. And there will be some cells in the vitreous and which cannot be really missed. And OCT can also show contact sign, and that where is that neurosensory retina is getting attached to the dome shaped one, touches the one that's described by Salman from Trichy, and this sign is to be quite important in diagnosing a tubercular granuloma or tubercular choroidal lesion. So I don't think that a look itself is not, to me, is convincing for a tubercular granuloma or tuberculoma of the choroid. So as Dr. LG has rightly showed, we have seen such tuberculoma in the HIV positive patient where there is less amount of cells were there, but they start with a small lesion and then they become bigger in size. It's not like, without notice, it can attain such a large.
Yes, sir. Very true. That is why this patient is actually being, presented here, because we thought these are all quite a diagnostic dilemmas, because number one, the age group is more in favor of a neoplastic entity. The history of smoking, that is the number two factor. And the third thing, the FFA, which is also pretty silent, which is also in favor of a neoplastic entity. So that is why we thought we will present it here, so that we will have more clarity onto the how to proceed with the patient. So right now, as of now, the patient is having improvement, but I'm yet to see the patient. So to see how he is going to progress. And then the next planning is, since we have not had any other pointers, we are giving him currently ATT and steroids. If he does not get better, the next thing is to go ahead with the choroidal biopsy. That is what we have planned. Yeah, now with that, I think we will, Dr. Shrika, ma'am, you want to say something?
Yeah, very basic queries. From the ultrasound, the appearance of the lesion, doesn't that tell anything about the cause? I'm sure, like usually in inflammatory lesions should be kind of mixed intensity, and these patients, if you do MRI, the surface spoils, usually the radiologist is able to differentiate the inflammatory causes, which will have a little bit of some amount of fluid that can be picked up. And here it's a very, if you go back to the ultrasound, I'm sure LG sir and others, from the appearance on the ultrasound, it's a very smooth contour, the surface, and as well as the substance of it. So, I would like to comment on the ultrasound.
Yeah, see, as I said, looking at the ultrasound, I would definitely not consider an inflammatory granuloma as the first option, first choice. I probably will share with you one case of a elderly lady in around the same age group with a similar kind of a picture of a relatively flat lesion, which is not having the mushroom shape of a melanoma. So you will automatically not think of melanoma because of the lack of mushroom shape. But there is a variety of diffuse infiltrative melanoma which can mimic exactly like this. In fact, that case, the diagnosed first suspicion was as a secondaries, because she is a known case of carcinoma breast, had a chemotherapy and all that. But that was about 8 years back. So because of the history, we thought first in terms of secondaries, because secondaries can be more flat compared to a melanoma, which tends to be more anterior-posteriorly growing. But there are exceptions. As I said, a melanoma can grow flat also like this. And in fact, that case, when we did biopsy, proved to be actually a melanoma, not a secondaries. And it was amelanotic as well. So in this case, I would still keep melanoma as a very strong possibility. I think when he comes back, if the lesion is not increasing in size, I would definitely do a biopsy. And the question for you, yes. The answer for your question, whether ultrasound can identify, yes, in a typical case, it can identify. So something which is flat, it need not have all the specific features like choroidal excavation, orbital shadowing, those features, and also the angle kappa. All these need not be there on ultrasound when the lesion is relatively flat, like in this case. If it proves to be melanoma, the ultrasonography definitely is not of a typical melanoma. Typical melanoma, yes, what you said is correct. There is initial high spike followed by rapid decay because of the absorption. Then there will be choroidal excavation and orbital shadowing, etc., etc. Those need not be there if it's a flat.
Another thing that isn't time important if we are thinking of malignancy. Shouldn't there be some kind of urgency in ruling out, it's talking about metastasis and things like that? Can we, doing a little more aggressive approach, wouldn't that be better?
No, that is why his whole, the whole PET CT with an MRI, both was done. So the patient has undergone a whole body PET CT with an MRI, and he is also being followed by the oncologist as well. So because he's also, his lung lesions, he was not symptomatic. Except for the smoking history, we did not have anything else.
I think it's a question for which there is no clear-cut answer. Obviously, because initial suspicion was not more towards malignancy, but more towards inflammation, the anti-inflammatory treatment was started. Having started, yes, you compare and then evaluate, and if there is no shrinkage of the tumor even by an iota, you are definitely a biopsy. The important thing is how long to wait. I think that's not a question for which, again, there's a straightforward answer. But if it is PET scan elsewhere in the body is normal, that does not mean the ocular lesion is not a malignancy. That only rules out a secondary, agreed, but does not rule out a primary in the eye. So it would still need to be watched very carefully and maybe as quickly as possible. If the patient's appointment is too far away, you might as well call him and ask him to come immediately so we can compare the lesion size, basically, an ultrasound and see if there's a reduction or not. If there is a reduction in the tumor size, the elevation lesion size, it cannot be a melanoma. It cannot be a secondary. Because they will not shrink with ATT or steroid. Okay? But if it doesn't shrink, I think we are justified in doing immediately a biopsy. Thank you.
Yeah.
Actually, in fact, my first diagnosis in this patient was like when I saw the patient first, I thought maybe we are dealing with choroidal mets only. That's the reason I went in for a PET CT also. But on the other hand, back of my mind, there is another entity like uveal lymphoma that can still be there, because lymphomas, if uveal lymphoma, if we are dealing with, we can still have flat lesions. So that's why I said, okay, having started already on this ATT and all, we'll go ahead with it. And if there is no change that is being noted, because he himself is as I told you, he's a medico. So he's and he himself is a radiologist. So I did not want to, so I told him we will watch for it. But so I called him in the November. He's coming in the first week of November. So we are going to see how much the changes are. If there is no change, we have already decided that we are going with biopsy. That is the plan. So, JB sir, you wanted to say something?
No. I agree with the line of management. So I agree that, inflammatory lesion will get regressed or remain same. But metastasis or malignancy will definitely increase in size over the period of time. And this is not a posterior scleritis also, because although there is a little bit of pain is there, we didn't see that other changes in the sclerochoroidal layer, like T signs or widening of the tenon space.
The FFA was also not typical of a scleritis as well.
How aggressive is a biopsy? I mean, like, how invasive is a biopsy as a procedure?
See, in this case, you can do biopsy both transvitreally and also externally. In fact, the case which I did talk about, I did both ways, because the pathologist there who was dealing with it was not experienced in doing a evaluation of few cells, unlike Krishna Kumar, who is excellent. So if you give him few cells, he will tell you definitely what it is. But that particular pathologist said, I want a good tissue specimen, which you can't get with a needle biopsy. So I did FNAC by using a 27 gauge cutter. What we do is, in this case, use a 27 gauge cutter using a chandelier light, no vitrectomy, but push the cutter through the lesion and then cut as you suck with the instrument, so that whatever cells come in the shaft are again flushed out into a small container and then given to the pathologist. Rather than trying to just put a needle and suck. If you just put a needle and suck, you may not get any cells if they're very closely adherent. While if you actually cut along with the 27 gauge cutter, with a very low cut rate, of course, then you'll be able to get it. The second way is that, of course, right over the lesion externally, you make a scleral window and then cut out a small part of the lesion and take it out and send it for biopsy. So both are possible, and in fact, in this case, both are easily accessible. Even externally, you should be able to do it because it's almost coming until the mid-equatorial region. And does not have any risk of RD and all that. The risk is very low. So as a first stage, maybe you can do a transvitreal biopsy. If it is negative or If the pathologist says there are not enough cells, I can't comment, then we have to do a choroidal biopsy from outside.
Taken point, sir. So the route for biopsy is either visual or the transscleral. Either way we can do. And like how sir very well explained, so one of the modality, whichever a person is comfortable in doing, can do either. Now with that, we will move on to the next patient whom we have. So I will invite now Dr. Divya to present the next puzzle.
Thank you, ma'am. Now moving on to the second case, we have a 29-year-old male patient, and he had presented with diminution of vision in the left eye since 1 month. Before that, he had a history of demyelinating neuropathy. He had weakness of his left neck and body, and he was diagnosed to have polymyositis, and this was lasted from December 23rd, 2023 to July 2024. And the treatment was given accordingly. Anterior segment findings are left eye has visual acuity of 6 by 7.5, and rest of the anterior chamber is normal, and IOP is 12 millimeters of mercury, and right eye has normal. When we look at the fundus photo of this patient, we have a subretinal mass which is almost occupying the entire temporal half, and it has whitish lesions on the temporal side, which we can see, and it is surrounded by the subretinal fluid. So corresponding blue autofluorescence can easily show us the delineation of the SRF from the lesion. Also has a infrared autofluorescence, and that is showing the delineation of the lesion. As now coming to the USG, USG is showing a dome-shaped mass lesion, and it is having a high surface reflectivity with homogeneous moderate internal reflectivity, and this lesion is measuring around 8.02 millimeters of horizontal measurement with a height of 4.15 millimeters, and vertical basal diameter is 4.74, and this is associated with retinal detachment. Correspondingly, we have done OCT in this case, and the OCT which is passing through this lesion, it is showing whitish hyperreflective foci in this area of outer, almost in the outer nuclear layer, not in this RP layer. So this could be the byproducts of the photoreceptors. So it could not, need not be true. Followed by this, we have done FFA and ICGA, and initial picture is not that significant in this case. And as the FFA is progressing towards the mid phase, we can see that there is pinpoint leakages in the center, almost involving all the and corresponding ICGA is showing hypocynescence. As it is progressing towards the late phase, the pinpoint fluorescence is increasing, and it is almost covering all the entire lesion. And the hypocyanence is also following, and it is a patchy hypocyanescence which is seen in the eye. The patient was followed up with a PET CT with fusion MRI, and this was showing a well-defined enhancing lesion, and it is measuring about 10 into 5 millimeters, and it had a low FDG uptake of SUV max of around 2, and it indicates that it is a low metabolically active lesion. And MRI is showing T2 hypointense, and there is no obvious restricted diffusion. These are the images of the PET CT with fusion MRI. This is again followed up with histopathology. So the histopathology report says that it is a pigmented tumor arranged in clusters and nests. Usually it is surrounded by melanophages, and it is giving appearance of a possibility of a RP adenocarcinoma or a possibility of choroidal melanoma. So this actually has to be.
Now we will request our pathologist, Dr. Krishna Kumar sir, to comment on this particular biopsy. He has put a message in the. He is actually currently sharing the IHC of this patient, that CK is negative. And because this patient's report as SOX10 is also negative, that is what it is. Like in this patient, the features which was there on the ultrasound, like the anteroposterior growth was not there. See, he's a young patient. This patient is in the age group of 30. If you see, the height is 4.15 and the circumference is 8.
This patient is 64, Suganeswari.
Which patient?
Am I wrong? Sai? This,
No, this is not 60. This patient, this is
a 29-year-old male.
Yeah.
29-year-old.
Yeah. I am treating all these 3 patients, so I know very well what age group they are in.
I'm sorry.
Yeah. So this is a 29-year-old patient who comes with a circumferential diameter of this 4.74 with 8 and a height of 4.15. So we are not having anteroposterior growth. We are having a tangential growth here more. And the other thing is, like, if we see the features on the ultrasound also, usually what happens is, like LG sir had just now pointed out, like in a melanoma, if your tumor height is more, then we have all the classical features. If the height is not more, as it becomes, the medium or the small one, small one is always a challenge, but in a medium size, it should not be. But in this patient, if we see how the picture is, can you put the fundus photograph? Yeah. So now this is the picture. So now I would like to request LG sir.
Yes, I'm here.
Sir, this patient, we went ahead with the biopsy because the MRI was also not in favor of a melanoma. So what we have currently obtained is his SOX10 is negative, CK is also negative. And so now we are not dealing with a melanoma.
No, I think if you see the last comment of Dr. KK, is that being a small sample, it may not be representative.
Yes, because this is a biopsy thing, and very few cells were only given to him.
I think for this is a case where I would go ahead and do external biopsy, larger window, large sterile window, and then take a good sample of at least about 3 to 4
Are we audible now?
Yes.
Hello?
You're audible, sir.
Okay, see,
you're audible.
just now he spoke to me. He said SOX10 is negative. SOX10 negative money, it means it is not melanoma. It is not melanoma. And CK he said is negative. So he's doing the other panel and he says the sample is very small. He says he doesn't want to give a negative report. He says there is a mass you are telling. So he says he'll do, and we will discuss the case on Monday or Tuesday, finalize out. But is it possible to provide more adequate sample, Dr. GSI?
So right now what we can only do is because we have taken the internal sample, we can do the trapdoor and we can do, sir. We can do. It's not a problem.
But there are only thing is go back to the images, no doctor. I'll just tell you pathology images. See here, you found it is a tumor. It is a tumor showing nuclear atypia. The other thing is metastasis, but you said PET scan is negative.
Yes.
But is it possible to have a with PET scan negative, Dr. GSI?
There are cases that is being reported, sir, that no primary has been found, but yeah, there are mets being found also. There are cases reported.
The only thing is now there is a tumor, there is a mass. It is not inflammatory cells. You find the cohesive cells. Next slide, doctor. Next slide. You find this sort of an adenoid pattern. So the dilemma is, it is not an inflammatory pathology. Usually we don't see melanoma, but common things are common. No, because of the pigmentation, we have to err on melanoma. But we are not seeing that because we have seen so many melanomas. So we have to be very careful before telling it is not melanoma. He has done only one marker SOX10. We will think about it and get back to you. At this stage, we definitely don't have diagnosis from the immunohistochemistry side, Dr. J. I will see what LG sir and others tell on this.
My comment is that this is an eye with useful vision and a young person. If it's a large tumor with relatively less vision and all that, then probably you will enucleate the eye and give him a full tumor for a diagnosis, proper diagnosis. But this is a useful vision, an eye with useful vision, and is a young person. So we are justified if he is unable to come to a conclusion to go and do his external biopsy.
Sir, can brachytherapy per se help him, sir? Without biopsy, can we do some brachytherapy?
I think doing a treatment without a diagnosis probably is not really appropriate, because the long-term prognosis is totally different depending upon what the histopathological diagnosis is. If you're not sure of the diagnosis, better to have a bigger chunk with which you can make a conclusive diagnosis and then proceed with the treatment. Brachytherapy is still possible, no doubt, but that can be done along with the biopsy also, if only we have brachytherapy available. And then At the same time, when you do a scleral window and remove the biopsy, you can put the plaque right then and there.
Sir, give time till Monday. We'll be completing the panel. Then we'll be able to take a call and inform back to the team, sir.
Good.
So that is a very interesting take on this. So sometimes what we have also seen in patients who have these kind of lesions are like lipoma. We have also encountered lipoma, but of course they are in a female patients, little elderly female. Elderly female is in the sense that in the age group of 40 plus, 50 plus, we have seen lipomas which are being seen. They will have a capsule that is pigmented, and then you have a trans-illuminating lesion, but they are more so seen anteriorly, not like this, which is like a posterior lesion. I'm sure Dr. KK will remember one lady who came to us and she was having a renal cell carcinoma. And so everybody's thing was the moment she had a choroidal mass, everybody thought, yes, we were probably having a choroidal metastasis. But when we went and did the biopsy, it was a lipoma. So it was a posteriorly locating. So immediately the staging, everything kind of changed. So we will not be surprised when you have a mass lesion. So this particular case is also being presented here because of the diagnosis not being straightforward. And we are still in a dilemma because one is because the sample is really small, and once maybe we complete the entire panel, we might have more information to add. So not that all pigmented lesions are melanoma. And yet another thing is like how LG sir pointed out correctly, that is, if you don't have a diagnosis, there is no point in treating, because if we assume that this is going to be a melanoma and we treat it, and if this is going to be an entity which is not going to be systemically metastasizing and it is going to be a locally invasive lesion, we may not give the patient the correct prognosis. So that way we will be erring on the wrong side. So it is always better that if we don't come up with the diagnosis in this, then we go ahead taking the biopsy by the trapdoor technique we can do, and that is another way of approaching this. So with that, now we will move on into the third case of the day today.
So the third case here is a 48-year-old male. He presented to us with diminution of vision in his right eye since 15 days, and he denies any other systemic history. On anterior segment examination, the vision in his right eye was 6/12 with a normal anterior segment examination, an IOP of 16 millimeters of mercury, and obviously a reduced color vision of 0/21. His left eye was normal with a vision of 6/6, a normal anterior segment, IOP of 16 millimeters of mercury, and a color vision of 1/21. His fundus examination showed a uniformly elevated choroidal lesion with variable pigmentation at the posterior pole abutting the optic nerve head. And parallelly, the autofluorescence showed these hyper and hypo autofluorescent spots, and again the margins of the lesion with the abutting of the optic nerve head. The hyper autofluorescence at the bottom showed the fluid presence. On ultrasound B scan, there was a lobulated mass lesion with medium internal reflectivity and an associated retinal detachment. The measurements of the lesion were the circumference, that is the horizontal basal diameter of 13.99 millimeters compared to a very low height of 5.11 millimeters. So on FFA and ICGA, early phase, we see very pinpoint hypofluorescent spots, and parallelly the ICGA shows the margins of the lesion with hypocynescence. Moving on to the mid phase, the hyperfluorescent spots were increasing and the ICGA did not show anything else other than the margins of the lesion. In the late phase, we had multiple diffuse hyperautofluorescent spots corresponding probably to the pigment and with surrounding SRF. I'd like to point out that there was no intrinsic vascularity noted in this FFA. We did a PET CT and there was a FDG avid enhancing lesion with restricted diffusion in the right choroid with an SUV value of 4.7, measuring 14 into 15 millimeters. On the fusion MRI, the lesion was T2 hypointense with surrounding T1 hyperintensity, suggestive of hemorrhagic component. The PET-CT features were also suggestive of a primary malignant lesion in the lung with multiple metastatic lesions in the rest of the body. This patient had metastatic lesions in the brain, the liver, bilateral adrenal glands, the right kidney, bones, cervical and abdominal lymph nodes. So to summarize, this is a case of a 48-year-old man with a uniformly elevated dome-shaped unifocal lesion associated with secondary retinal detachment. And as the literature suggests, that it was most likely choroidal metastasis, which presents in 5th to 6th decade with a dome or a plaque-shaped lesion, which is similar to our case, which it can be either unifocal or multifocal, unilateral or bilateral, and has presence of lipofuscin and extensive SRF. This patient also underwent genetic testing and came out to be ALK positive and is currently being planned for targeted chemotherapy.
So in this last case which we had discussed, who is like, the patient's age is currently very young patient, he is relatively, and if you say he's only 48 years old. So contradictory to our first patient, wherein 60 plus patient, we always would think him to have a carcinoma. So this is a patient who is 48 years, and usually to think that this patient to have a choroidal metastasis with having, he had multiple organ involvement. So currently the thing is, they have initiated him on chemotherapy. He is currently with Tata Memorial Hospital, and he is also now his genetic testing being positive. So they are now on the discussion, the tumor board, for the targeted chemotherapy. So now for him, this is, in these particular case, there is no, there's no big challenge for us. So it is going to be a problem only if he does not respond to the therapy, and if we are not seeing signs of regression of this particular patient. So the plan for this patient is, we have asked him to come back after completing 3 cycles of chemotherapy to see the interval change. So now can I request LG sir to comment, please?
Not really much of a comment, because since diagnosis is already made, as you said very rightly, we wait for the response of the systemic chemotherapy or whatever, targeted or non-targeted chemotherapy. And then if the tumor is persisting, then we can advise them to have irradiation done locally. And if it's very small, of course, you can even do brachytherapy. And if it becomes smaller but still persists, you can add on top of it TTT to destroy the local tumor. So the ocular treatment can still go on irrespective of the complete cure in the systemic condition, but as long as the person is alive, let him at least have useful vision in the eye. So we don't stop treatment for the eye just because we know he has got systemic metastasis all over the body. So what we do is try to treat the eye while continuing with the systemic treatment. And once we wait for the shrinkage and then continue with local treatment.
Yes, sir. So that is a well taken point. As in this particular category of tumors, our role becomes very minimal in the sense that we don't usually go ahead doing the biopsy of this particular lesion unless and until if we don't see any kind of regression. In that case, probably we add on the treatment, like utilize the radiation therapy, either do radiation or like sir pointed out, the superadded TTT. Even then, if it is not regressing, then we can probably take those lines also. So actually now these 3 patients which we have actually presented today, they are cases in which sir, LG sir, you have some points?
No. Yeah, I just wanted to share with you the importance of not of continuing with the local treatment to preserve the eye. By quoting one example again, it's about a 40-year-old lady who had carcinoma breast, secondaries in the brain as well as rest of the body, and choroidal metastasis, unilateral choroidal metastasis. And then after a local radiation to the orbit, it shrank a little bit, but it was persisting with some SRF and all that. I went on treating with TTT, and I remember that this patient is now 3 years since the metastasis was identified. She's absolutely alive, and she comes to the hospital on her own, no problems. She's able to work. And for so, they were able to prolong her life. Not only that, even the quality of life is pretty good with the chemotherapy, targeted chemotherapy. So don't give up on the eye just because patient is having a systemic metastasis. You should continue to try and preserve the eye.
That is a really wonderful point, sir, because now with the multiple modalities of treatment, it has become very clear that even in a stage 4 disease, one should not stop treating, because these patients, they are not like yesteryears when we used to think that if they have a metastasis at multiple organs and with the stage 4, we should not tell them that no, this is the end of the story. No, not that way. We should continue treatment, and these patients are to be monitored. And usually what we kind of do is, like when the patient is on active chemotherapy, once in a 3 months should be good enough if the patient is not a localite. But if after the completion of the active chemotherapy, and even after that, if the patient is harboring an active disease in the eye, then they need a very short follow-ups, like once in a 8-week follow-up, and the treatment also simultaneously should continue. That is how currently that these patients are being monitored. And the most important thing is, initially we used to have very small range of diagnosis as far as the choroidal lesions are concerned. But now the plethora of diagnosis is constantly been increasing. Like for instance, like we tend to see from adenoma to adenocarcinoma to schwannomas, which were once upon a time not, probably we did not have the technique to detect the tumors, or the expertises of the probably at that time for us to get the specimen out and all those things. There were a lot of difficulties. But now with smaller gauge instruments being available, and with multiple modalities of investigations being available, like the immunohistochemistry, which comes into a huge rescue for all of us. So those are things that one must keep in mind. So now I would like to request Dr. Krishna Kumar sir. KK sir, you're there? I think he is not, he's probably muted. Yeah, KK sir, can you probably help us with few things about the immunohistochemistry itself? Is he there?
No, he's written in the chat. He's there, but maybe a little. There's a problem with the mic or something. You're muted, sir.
No, my Mac is not opening, so I'm going back to Dell to open it. Am I audible now?
Yes, yes.
See, immunohistochemistry is very helpful if it is not a pigmented lesion. If the lesion is not pigmented and the sample is adequate, because it has to go through the machine processing. And if you give me adequate even 10 cells or 15 cells, if it's amelanotic, doctor, we can crack the case. If it is pigmented, then immunohistochemistry is technically challenging, because the pigmented cells are all HMB45, SNet positive. So then it will be a big problem to diagnose melanoma. That's the reason. But immunohistochemistry is really very, very helpful in solving many of the spindle tumors, whether it is leiomyoma or melanoma or some other tumor. Immunohistochemistry is a great help, doctor. We always do panels to make a diagnosis. We don't do single marker. So, because since Dr. JSA had asked hurriedly what is, he said SNet negative. Let us see. We'll wait for tomorrow. I'll talk to him again. He'll do the other next 3 more panels to see at least any other marker is positive. I'm not able to think of any other tumor in this location. RP adenomas. Recently we had Dr. Magesh Shanmugam's case. It was a young boy, age around 28. He had a ciliary body pigmented mass, and there in Bangalore they gave a report as melanoma. but he did, I think sir did ciliary, that's what those days LG sir used to do. He did that iridocylirectomy, something like that. And I saw the slide and I told MPS it is an low-grade adenocarcinoma, CK was positive, and I was very glad. So only thing is next whether I am looking at an adenoma, but is it really a choroidal mass or an, how is the mass, doctor? From MRI image and other thing, what is the gut feeling?
Sir, so far it doesn't not appear to be at the level of RP. Like for if we have done the OCT also, I think Divya, can you share that second patient's OCT?
Yes.
Yeah. So now if you see the lesion here, sir, it is not coming from the RP. It is coming from the choroid only. So it's obviously not anything to do. One differential can be is melanocytoma, but melanocytoma has to be even more pigmented.
Yes, and melanocytomas will be ascended positive. Any melanin lineage will be ascended positive. So only thing I need to look into the slide tomorrow only, but Monday only I'll get the slides, doctor. Definitely it is something is there. Let us complete the panel and get back to you by Monday. But immunohistochemistry is very, very helpful in tumors which are not pigmented. The tumors are pigmented, even molecular testing, the melanin pigmentation interferes with the real-time PCR, interferes with the NGS. So a lot of quality controls has to be done.
Yes.
The second patient had some systemic illness also, some demyelination, myositis.
Yeah, he had polymyositis.
Polymyositis and some demyelinating neuropathy also. Was on oral steroids.
Yeah. So that was in the last year. He was getting treated in the last year he was having. So right now he is not on therapy, of course. So this is another patient on whom we still don't have a working diagnosis as of now. So the plan is once we get to know the panel completely, then we will, if we get the diagnosis, we will go ahead with it. If not, then we will probably think about a biopsy from the scleral, because we definitely need to have a diagnosis for this particular patient. So now with all these cases which are kind of challenging, so we thought we will present those cases which are not straightforward cases, but still cases which can probably help us in better understanding. So I would like to thank LG sir, JB sir and KK sir for being here today, and then highlighting the most important factors into understanding the disease. Sir, LG sir, I would like to ask you one question.
Okay.
Sir, regarding this metastasis in melanoma. Metastasis, the liver metastasis.
Okay.
So how is your experience on treating these patients with liver mets and all those things, sir?
I think if it's an isolated nodule, they do surgery to remove. In fact, there is one of my close friends in Singapore her mother-in-law developed secondaries in the liver. What they did was they actually diverted the circulation of the liver to one lobe in which the tumor was not there by doing a shunt procedure as a first stage, so that lobe started to increase in size. And as a second stage, they removed the other lobe in which the tumor is located, while of course she was already on chemo. So but that way they were able to sacrifice a smaller part of the liver and retain a larger part of the liver, rather than de novo going straight and removing the tumor. So you are left with only a very small amount of liver to function. So that was a very, very intelligent way of managing it, wherein you actually make one part of the liver grow by diverting the circulation towards that side, and then remove the other side of the liver which is having the tumor. And that lady is quite okay as of today. But in general, although there is a short-term success, long-term still the mortality rate is quite high once the liver is involved. Yes.
And have you seen patients with these therapies like this sunitinib and valproic acid? Have you encountered any of those?
I am not sure about the details of the treatment the oncologist was doing, but I only know that there are people who do intra hepatic artery chemotherapy, as well as by guiding a catheter and injecting directly into the liver, and also after shrinking it, removing the tumor by letting the other part of the liver function. Like that, people have tried, but still, you can also understand that they may have at the same time metastasis elsewhere in the body, then it's not going to work. But it's isolated liver metastasis with a melanoma, since that is the commonest site, some success has been seen with treatment, but you require very aggressive treatment and really were a dedicated team to do it, which I'm not sure in the usual course of events we can afford it in this country. But yes, it is possible to prolong the life, not necessarily to cure them completely.
Sir, you have seen both the populations, like in India also and in Singapore. So, like for instance, the amount of metastasis that you see in the other population, we don't see that many metastasis with the melanomas which we have seen here. Though we have had class 2 also, but even then we have not seen. So, do you think there is a variation in the races among?
I'm not very sure. I think that could be also a problem of follow-up, and could be a problem of ours being a tertiary care center, a referral center. And unless you are able to actually diligently follow up all the melanomas that you have seen and whom you have enucleated, and actually talk to them and say how they are doing, etc., and examine them periodically, or get at least the oncologist to report to you, we cannot be sure about whether our metastasis from the melanoma is the same or less than in the West. That's a fundamental question. While in a place like Singapore where I worked, there was no problem because it's a small country, and the people, if they don't come, the hospital staff continuously on phone with them, asking them to come for a checkup. And if still they don't come, they send a social worker and literally physically bring them for a follow-up. So that being the case, you can pick up metastasis very easily because they are diligently followed up. And I'm sure we have a lot of problem in having such a diligent follow-up unless they come to you. And very often if they have a metastasis and they are on the sick bed, they may not opt to come to an ophthalmologist. They'll go to an oncologist, get treated, and then probably pass away. So you may not know that the patient actually passed away because of metastasis, because he never reached you.
Yes, sir. So actually currently what we are trying to do is all the class 2 melanomas at least, we are kind of maintaining a register so that, we can call these patients up and at least the class 2. So the class 1 we are not so much aggressive on, but class 2 we are trying to maintain the follow-up because we are doing the BAP1 also. So KK sir, can you tell us something about the BAP1?
See, BAP1 is a BAP1 mutation is seen in class 2 melanomas according to the literature from Emory University and from the group from Florida. And what Professor Hans Gross-Nicholas and Sarah Kupran suggested is that you can do a protein marker. So they suggested BAP1 antibody. It's a polyclonal antibody from Santa Cruz, and they suggested you do by immunohistochemistry. And the normal cells will have nuclear protein, nuclear expression of BAP1, and in melanoma cells which are belonging to class 2, the nuclear expression is decreased or lost, and there will be faint cytoplasmic expression. We need to use ordinary nevus, skin nevus as a control where you can see the nuclear expression. The catch is it is not a CLIA certified, that is, it is not a diagnostic approved antibody. So we have to be very, very careful. And I spoke with the pathologist from Singapore, and they said the same antibody shows variation or variability in the study, and it is not correlating. That's what she said. I said the same thing is there. I'm a bit reluctant to give a report on a antibody which is not CLIA certified. That is, it is not a diagnostic antibody. We have to be very, very careful.
Yes, the only point I would like to say is that all those chromosomal studies, analysis, etc., they only give you a possibility of a secondary. Doesn't mean secondaries will not occur. And at the end of the day, the proof is whether secondary has occurred or not really what the pathology showed. So I think it's important for us to really have a long-term follow-up very critical follow-up, which unfortunately in India people don't tend to. Once the eye is removed, very often they think that it's all cured, and they will never go for an oncology checkup unless we push them hard. They may go for one follow-up, second follow-up, then they say, okay, I'm all right, so they don't come for follow-up at all.
Very true, sir, that to maintain the follow-up for these patients, it is sometimes becoming very difficult for us to do once enucleated, like rightly you pointed out. So what we are currently doing is, we tell them, if you're not able to come here, what you can do is you can send us your metastatic workup. So we tell them to send their ultrasound abdomen, X-ray chest, and their liver function test. So this is an easier thing that they can mail at least the reports to us, and they can take a picture of the socket also and send it. So if they are not able to reach for whatever circumstances, they can do that. This is one another way which we are currently now encouraging our patients to do. So post-COVID, I think apparently now they have also started realizing the importance, and they've started sending the pictures and these things once in a 6 months if they're not able to come here. So that is what currently we are doing. So I think so now this is one good useful hour which we have all spent together, and it is Dr. KK sir, you want to say something?
Dr. GSI, in our study on melanoma, I think LD sir is that we found chromosome 6q deletion was very, very significant than monosomy 3, and melanoma tumor volume was very significant. So currently Dr. Veena does not give tumor volume measurement. If you can, all the cases MRI, if you can ask her to do tumor volume data, she said, KK, if JC is asking only, I will give, she's saying. You ask for tumor volume data, doctor. If you do tumor volume data, there is a paper, there is a cutoff. The high tumor volume melanoma cells all do badly according to data published from literature. So if you can get data from Veena on the tumor volume data, and whatever enucleate we do, look for capillary loops, epithelioid cells, mitosis, necrosis, tumor infiltrating lymphocytes, we go back to the old pattern. And with all these things, we will put a risk score. It's high risk histopathology melanoma. Tumor volume is large. So you have to follow up, or that's all we can do, Dr. JSI.
Risk scoring. So you are talking about risk scoring in these patients.
Yes, doctor. So tumor volume is very, very important. See, once you enucleate the tumor and put in formaldehyde, it shrinks. MRI tumor volume data, that's a formula which she has to do. Without you asking, she's not going to do that. That's what she told me.
No, we'll have to tell her that should be a mandatory prerequisite which has to be incorporated in every scan report which she has to send. We can always ask for it, sir. We can tell her that should be a default thing.
You have to tell doctor, because she did something for our project, and we have some data on tumor volume which is very significant in all chromosomal 6q deletion. So ask her for tumor volume data, doctor, in on MRI. That will be adding a wonderful thing for you, so that you can even before enucleation, how does the tumor stand, which class 1 class.
Definitely, sir. So this is another point which we can always work it on. That is, so that's a wonderful thing. So now with that, we come to almost the end of this session. So I will request Dr. Mona Kurana now to come up with a summarizing.
If the tumor biopsy cells have been taken, can a gene analysis be done and thereby be able to predict which are the ones which are likely to keep recurring?
Sir, we contacted the Castle Diagnostics in Seattle, sir. They said they will never do for samples from India, as they have not validated the gene expression profiling on the Asian Indian population. Currently, it is tested only for the Caucasian population. I had emailed a couple of years back to Castle Diagnostics. Unless until you validate the data in the Asian Indian population, then you cannot follow that profile.
If there are any other questions from the audience, we will definitely take it. So if there are none, then I will request Dr. Mona Kurana to please conclude the session with summarizing the event.
Thank you, Suganeswari. That was an excellent discussion with excellent cases. So, in solving the pigmented puzzles, it is important to differentiate tumor from rubor, as we saw in our first case. So, whenever you see that there is a focus of inflammation, let it not misdirect you. Always look out for any tumors, especially if there are no vitreous cells and the AC is quiet and the patient is immunocompetent. OCT can help us in picking up subclinical vitreous cells, and it can also show the contact sign, as Dr. JB suggested, which is seen in tubercular granulomas. A silent FFA is more suggestive of a neoplastic etiology. Still, if you think it's inflammation, you can treat but monitor very closely, especially the size on B scan, and follow up the patient very closely. And if you see that it is not regressing, then don't hesitate to go for a biopsy. It may be a neoplasm. Biopsy can be, as we saw in our second case, either a transvitreal biopsy, or we may need to make a scleral window. If we make a transvitreal biopsy, we can do a FNAC with a 27 gauge cutter, as Dr. LG sir suggested, using chandelier light. And you cut as you aspirate using a low cutting rate, and whatever's in the shaft you can give for the biopsy. But sometimes, like we saw in the second case, we know it's a tumor, but we don't know what it is. So then we may need to go in and make a scleral window and get a larger sample, and then accordingly, as with expert like Dr. KK, we can have the diagnosis and we can manage the patient. So sometimes we have Mets, and in such a case, we should never give up, because there are still many options available now, like chemo, radiation, brachy, TTT, and immunohistochemistry in pigmented cells is challenging, whereas it is better in non-pigmented samples with adequate sample size, of course, and especially spindle cell tumors. And you should always be innovative in treating, like, for example, using growth to treat growth, like Dr. LG gave the example of how we increase the size of the healthy liver and then take out the liver which has the mets in it. And always be innovative for the follow-up, because follow-up is very important even after the treatment. And you can use tele-ophthalmology, like Dr. Suganeswari suggested, to increase the adherence to the follow-up, because till, like Dr. LG said, lifelong follow-up is important in these patients. And it's a lot of hard work which all of you are doing for this, and kudos to all of you. I think that you want to add to the summary.
No, you've summarized extremely well. So I think you can announce the next meeting. Next meeting.
So next month we'll be having glaucoma cases, and our presenter will be Dr. Shahinoor. I think she's in the audience today also. So we're looking forward to her presenting very interesting cases, and we'll just by next week come out with the whole schedule. So please look out for it.
So we would like to thank our panelists, our presenters for being here today, and we will be there back for the next POWWOW meeting in the next month. So thank you all of you, and have a good night.